Thank you for that kind, if not exaggerated, introduction. And I have nothing to disclose today. Sorry, just adjusting the mic. So basically, I'm tasked with discussing overuse injuries. So overuse injuries in a general sense are tissue damage from repetitive or the same activity over time. It can present after playing through pain and gradually getting worse and worse. And sometimes it can be acute on chronic, where they've had pain for a while, and then they acutely have an increase in pain, really preventing them from participating in activity. Similarly, like a baseball player who's had pain on the medial elbow, and then they throw that one pitch and have a pop and suddenly really can't move their arm anymore. That would be an example of sort of an acute on chronic type of overuse injury. There is a predictable progression to these type of injuries. Generally, it will start with pain after an activity. Now, if you've ever gone to the gym after having been there for a while, or if you're taking up the sport that you've done before, but it's been 9-10 months since you've done it, then you may have muscle soreness that first day when you're back, but that will typically resolve. You rest it, you stretch it, and then you go back, and each day there's less and less discomfort until your body has adjusted to the activity. Now, if it has not adjusted to activity, or not given enough time to rest, it's going to start having pain now during the activity. And then if the athlete continues to ignore that, they're going to have pain during the activity that inhibits their performance, making it more difficult for them to perform at the same level. And then finally, they're going to have pain just at rest. They're going to wake up the next morning from an activity and still have pain. They'll have pain walking around during the day. So I'm going to go through all the different types of overuse injuries there are, pretty much essentially one by one. We've got stress fractures, Ocd lesions, strains, and pretty much anything ending in itis. So there are different risk factors or contributing factors that will make one person more likely to experience an overuse injury than somebody else. Rapid growth, those tween years when they're going through that adolescent growth spurt, that is sort of prime time for an overuse injury. The bones are lengthening rapidly, and the muscle tendon unit does not keep up that same pace of growth, and so it gradually, essentially tightens up as they are growing quickly. That's why all you see, if you look at teens, with the exceptions of dancers and gymnasts who are constantly stretching, they're almost always tighter than their pre-adolescent counterparts. Likewise, with that rapid growth comes that lack of flexibility. Often they don't stretch enough. If they are even stretching at all, a lot of times they're just going through the motions and not actually feeling that stretch when they do the activity. And the muscle, in some sense, is kind of like a rubber band. If it has more flexibility, it can move farther before it starts to snap. And same thing with the muscle. If it's more flexible, then it can contract and expand much more easily without added strain or stress on it. If they ramp up their sport too quickly, if they're a cross-country runner and they haven't really been running over the summer, fall season starts and now they're suddenly running 30, 40 miles per week, their body is unable to adjust to that increased strain on it. And if they don't have adequate rest, which is also a part of this, then their muscle or bone don't have adequate time to repair itself, and they will start having pain. And finally, early sports specialization, where they are doing one sport and only one sport before the age of 12, is another risk factor, which I will address that one more so even later. So going through each of the different types of injuries, muscle strains on exam, they're going to come in complaining of pain. They will usually point to somewhere along the muscle belly itself. It's not typically a hard diagnosis to make. The child itself will sometimes come in and say, I pulled my quad muscle or my hamstring is hurting. They even know essentially what the diagnosis most likely is. Sometimes it is important, however, to rule out a bony injury. What you think might be a muscle strain could be a slipped capital femoral epiphysis or some sort of bone cyst. So it is important not just to assume because the child knows or you think that there may be a strain or a sprain that that's exactly what it is. They don't always have tenderness over the muscle itself, but usually with stretch of the muscle, you can reproduce that pain. So if they're complaining of pain in the area of the quad, and they're complaining of anterior thigh pain, which is a common complaint in a hip slip, if you have them lie prone on the examining table and flex their knee so that their heel is coming up to their bottom, you're not moving the hip. It shouldn't be painful in a hip slip, but they should feel that stretch and discomfort in the quad when you do a maneuver like that. Likewise, if you get them to use the muscle, again, using the quad as an example, if you ask them to extend their knee against resistance, making them use that muscle should also reproduce the pain, and also you should find some weakness in that muscle as well. Unless they have multiple muscle strains, it should really be isolated to the one muscle where they are anatomically pointing to. Bursitis. You're unlikely to see an example quite this severe in your office, but it's pretty illustrative of what bursitis looks like. This would be prepatellar bursitis, where the bursa superficial to the patella becomes very inflamed. They will have a very localized swelling, and the different areas of the body where you find bursae are areas where there's friction, where there's movement. So you'll have it over the greater trochanter, where the IT band can rub back and forth against it. You'll have it over the olecranon, where you've got that motion at the elbow, and of course the prepatellar bursa over there. Typically, what you're going to find is, again, it's going to be like a golf ball, or in this case, a baseball, sitting on the person's joint because that swelling is localized to this sac of fluid. The bursa itself, the whole purpose is to reduce friction. So if they are having a lot of friction in that area, either from repetitive movements or more likely from almost a sliding or shearing impact to that joint, then it's going to fill up with fluid, as bursas do, to diminish the friction. So someone of this nature is probably a wrestler, because they are constantly having shear forces across the knee as their knees slide along the mat. And they are probably the most common patient that I see with a prepatellar bursitis. Usually there's minimal warmth if we're talking about bursitis in the sense of an overuse injury and not as an infected bursa. Strength is often minimally affected, although they will be very tender over that area. And in general, and I'll go into treatment of things later, but generally I just avoid draining these, even though it is so tempting to just pop that little needle in there and suck out that fluid. So moving on to tendinitis, as the name suggests, it is inflammation of a tendon. It may be over the central part of the tendon itself, it may be over the insertion site, and similar to the exam on the muscle strains, the pain is reproduced when the tendon is stretched or when the muscle attached to it is asked to contract, like if you're, again, asking the patient to push against resistance. Tendinitis is more common in the adult population, so when I see it in children, they usually are really overdoing their activity quite a bit. Often they have a tight muscle, so there's more strain across that tendon, and if that tendon if you're examining a joint that tendon crosses, they will often have some limitation of motion at that joint. They also can be very tender over that tendon itself, unlike the muscle strain where they may or may not have some tenderness over there. They're usually over the tendon, they'll be very tender to touch. So apophysitis is inflammation of an area of growth that generally does not contribute to the overall length of the bone. So you get inflammation in the physis, in the growth plate, often where there's a muscular attachment or a ligamentous attachment. We've got all sorts of different names based on whichever orthopedist wanted to name something after themselves. Seaver's apophysitis is the growth plate or apophysis at the calcaneus. Island's disease is at the base of the fifth metatarsal. Osgood-Schlatters, which I'm sure as pediatricians you see a lot of, that's right at the tibial tubercle where the patellar tendon attaches. And Sindig-Larsen-Johansson's is right at the inferior pole of the patella. And again, this is due to generally repetitive trauma, ramping up their activity too quickly. If they are growing quickly, also, if they're having a growth spurt, that will contribute to this as well. When they're growing rapidly, the zone of hypertrophy in the physis will undergo a more rapid apoptosis in order to make room for the osteoblasts and osteocytes to come in and now populate that area. So that apoptosis, that increased cell death, will often weaken the physis when they're going through times of growth spurt, which is usually around early adolescence. During that time, they've also tend to build up a lot more muscle mass, which means the muscles are pulling harder on growth plates that can be weaker, being a real setup for an issue with the physis itself becoming inflamed. Oftentimes, they will be tender directly over that physis. You'll push on that medial epicondyle on the inner side of the elbow, and they will be tender directly over that medial epicondyle. You can also have it, which is known as little league elbow. You could also have a little league shoulder, where that is actually across the entire physis of the shoulder because of the high strain rotational forces as they are throwing a baseball. They can also have it over the iliac crest, which, if I'm not mistaken, my colleagues can correct me, I don't think anyone has yet named it after themselves. And an OCD lesion is a very different type of overuse injury. In this particular injury, they're getting an area of bone necrosis, which is often due to repetitive microtrauma. There are many kids who have repetitive activities, sports, for years on end that never get an OCD lesion. These are less common than other overuse activities. There are little anatomic differences from one knee to another that may impact the development of this. There may be genetic predisposition to this. Families always ask me why they got this, and really the only thing that the kids tend to have in common is really just that overuse component, but there are definitely other factors that play into it. The most common area is the lateral aspect of the medial femoral condyle. It's a hard region to find point tenderness because it's contained within the joint. So they'll come in with complaints of vague joint pain. They may have, as it advances further, limitations of joint motion. They may have full joint motion. It depends how advanced it is. They often have a joint effusion. Early on, they won't have a joint effusion. So it's often a difficult diagnosis to pin down until you actually take an X-ray, and then it's usually as plain as day on the imaging. And stress fractures is the final overuse injury I'll be discussing. Essentially, it is repetitive stress to the bone that results in elastic deformation, which also results in very microscopic cracks in the bone over time. So they come in with a complaint. Usually, in runners, it'll be around the distal tibia, which is also where they have shin splints. But shin splints are usually, the tenderness is just posterior to the medial tibia, while with stress fractures, they will have the tenderness directly on the tibial shaft itself. So it gives you an idea of which one of the two it might be, but the exam itself is not particularly diagnostic. Usually the X-rays will often, but also not always, have the answer. They usually have full range of motion of their joints. They usually will have full strength. The X-ray in a stress reaction, which is almost like a pre-stress fracture where there's been some mild breakdown of the bone, some chronic pain, but not to the point where the body or the bone really is needing to repair itself. So in stress reaction, the way to confirm that diagnosis, if it is necessary to confirm it, would be an MRI. A stress fracture, you'll see the periosteum starting to lay down new bone, like you are in image A over here, right over there. You can see that thickening of the bone. This is actually the same image, but same tibia, but a lateral view. And on that view, you're seeing what's called the dreaded black line, which is an indication of an advanced stress fracture that is at risk for becoming a complete or acute fracture, or acute on chronic. C and D is just that scenario, AP and lateral views. of a patient who had a stress fracture that went on to an acute fracture, where the difference between this and an acute fracture that did not start out as a stress fracture is that you already have that thickened thickened bone there from where the periosteum was trying to heal this impending break. In any athlete, but particularly the females, you want to check vitamin D level and that athlete triad involving disordered menses, whether or not there's an eating disorder, perhaps reduced caloric intake, and bone pain or stress fracture. So now that I've gone through all the sort of the different overuse injuries, next is the treatment. And a lot of patients come in kind of expecting me to wave my magic wand and make this all better for them. And unfortunately, that's not quite how overuse injuries improve. So rest. None of them want to hear that. If they were planning on resting it, they would have done so before they came in and saw me. And usually they are absolutely shocked when I tell them that I can't make this better for them other than advising them that they need to refrain from that particular activity. Must that rest happen immediately? Well, in some patients, yes. In other patients who have their national championship in something 2 days after they're seeing me, can they participate? I usually will lay out the risks for them, but oftentimes it's reasonable to play in that one more event before they ultimately rest it. Some athletes will just wait till the end of the season because they already know what I'm going to tell them. So they come in when it's over, and then they hear it from me that, yes, they need to rest it, and they're fine with that because they waited way too long. However, waiting so long means they're going to have to rest it that much longer. So when they come in thinking, okay, they finished the season, maybe 2 weeks off will be enough, no, they're probably going to need 2 or 3 months if they've been pushing through pain for that long. Nsaids, I find, are particularly helpful in those apophysitis, where the inflammation is in the growth plate. This will tend to help get that inflammation improved, but rest is still an important part of that because they still have to allow time for that to recover. Compression is mostly just for comfort. Stretching will not really speed up the recovery of their injury, but it will help prevent the muscle from becoming tight and help prevent a repeat injury. Foam roller, there's been some research recently that it does show an improved rate of muscle recovery in the athlete who has sore muscle, but as far as getting an overuse injury to heal any faster, I think the jury is still out on that. Physical therapy will often help them, again, with more so than recovery from this, which again primarily is just rest, help them build up the strength again, improve the flexibility, and help prevent another type of overuse injury upon their return. In sports that require a lot of technical skill, like throwing a baseball, it's not a bad idea to have a coach check their mechanics and their form and make sure that it's nothing that they are doing form-wise that led to this, because it will happen again as soon as they come back. When the pain is fully gone if you stretch the muscle, gone if you ask them to move that extremity against resistance, when it's fully gone, they should gradually return to sports. There's only so much you can test in the office, which does not replicate so well what they're doing out on the soccer field. So I always tell the athletes to gradually start doing some jogging. If that works well, do some sprinting. If that works well, then progress to kicking the soccer ball harder. And if at any point they feel like they feel something or it doesn't feel right, stop before they experience that pain. Maybe a little more physical therapy or a few more days of rest will be sufficient, rather than saying, oh, well, the doctor said I was fine, pushing through it, and then they end up back where they started again, which is frustrating both for them and for me. Bursitis and Ocd lesions are a little bit different animals than the other type of overuse injuries. With bursitis, since it is an issue of friction and movement at the joint, you want to avoid that friction. You want to avoid any pressure over there. Those I will treat with Nsaids because you really do need to get that inflammation down, sometimes even temporary immobilization. Like I said, draining it is probably not your best course of action, because just even putting the needle in the bursa will irritate the bursa, which will then fill back up with fluid. Sometimes a cortisone injection to the bursa will prevent that inflammation from recurring, but that's really something that I use as a last resort if they've gone 2 or 3 months of doing these other more conservative measures and it has not resolved. With OCD lesions, that's a talk unto itself, but essentially, the younger kids whose physes are still open, their healing potential is much better, and they might be able to heal these with a period of prolonged weight bearing. Now, prolonged non-weight bearing. That prolonged period is often 3 to 6 months, so it's really important to educate these families as to what they are in for with non-operative treatment. After that 3 to 6 month time, there is certainly also no guarantee that this injury will have fully healed. And then it may require surgery. Any unstable OCD or a child whose physes are closed will probably need surgical care. Prevention, I'll just rush through this quickly. Gradually ramping up activity levels, stretching before and after, strengthening to help keep the muscles strong. You're putting less strain on the bone and the joints. 1 to 2 days off per week from their sport, so multiple teams is not a good idea. Rest if having any pain, have the coach look at their form. 1 team per season for a particular sport is so important in avoiding these injuries, and yet athletes are doing this all the time. Avoiding early specialization in a sport, and because it bears mentioning again, rest if having pain. Early sports specialization is basically playing for 3 seasons or 8 months of the year under age 12 to the exclusion of other sports. So you're using the same muscle groups again and again and again without adequate rest. And the rate of overuse injury is so much higher if that's the case. Wilhelm et al. Found that in early baseball specialization did not improve the chance of becoming pro, but it did improve the chance of having an injury during your career. On the flip side, there is evidence that early specialization will increase your chance of a college scholarship, but if you overdo it too much, it also increases your rate of more severe injury, surgical injury, and then if that's the case, obviously lowering your chance of getting that scholarship. Thank you very much.